Good morning, everybody, and welcome to our panel entitled, as you know, Post-Traumatic Stress, the Ongoing Battle. Post-traumatic stress or post-traumatic stress disorder, as the full name is of course, a diagnosis that it can be only diagnosed 1 month after suffering a traumatic event. And the symptomology is well known to all of you: flashbacks, nightmares, increased sense of arousal, something called hypervigilance, which means you're always afraid that there's somebody who's going to pull a gun on you, and significant life impairment. And anybody who has had a friend or loved one who suffers from this knows just how impairing this can be. As we know, there are references going all the way back to the ancient Greeks to soldiers having suffered the symptoms of what we now call PTSD in combat. I think the earliest literature citation dates from the 3rd century BC, so we know this is not a new phenomenon. And we know that over the years it was called many things: shell shock during World War I, combat fatigue and combat stress. I remember visiting with some veterans from World War II in West Virginia several years ago who were still suffering from it. We're showing up weekly or several times a week actually, for therapy sessions at a vet center. One of them in particular I remember vividly was still, all these years later, having flashbacks of having been on a cruiser that was destroyed and being in a situation in the South Pacific where he was surrounded with sharks and watched some of his colleagues disappear as a consequence. So we know this has been around a long time. It was really only, though, in the 1980s that we came to categorize this as post-traumatic stress and gave it an official diagnosis, and it carries that diagnosis to this day. And again, prior to a month after suffering the disorder or the traumatic event, one still can have symptoms. They're just classified differently as anxiety, acute anxiety disorder. Then 1 month later, you can get the official PTSD diagnosis, for which I'm sure people are very grateful for the distinction, as they go through this. The battle in today's title has a double, if not a triple meaning. Obviously, the battle refers to the large degree of this issue that we're seeing as a consequence of the wars in Iraq and Afghanistan. And not just because of combat situations, also because of rape and sexual assault, which is more prevalent than we would like to think in the military. It's a battle in the sense that we're still trying to figure out how effectively to treat people. We've learned a lot in the recent period about effective treatments for PTSD. We know, for example, that prolonged exposure therapy seems to work for many of them. That is, it sounds inhumane, but it's actually exposing people again and again and again to something very reminiscent of the trauma that they initially experienced. So they essentially relearn how to respond to that trauma and, in effect, lay down new neural circuitry to enable them to respond in a different way. We know that we have a lot left to learn. We have a lot left to learn about what is the actual biological response that is producing these symptoms. Why does it hit some people and not others? We know that over a lifetime, 50 to 90% of people will experience some traumatic event. Why is it that only about 8% of them, on average, will experience actual PTSD? Why is the risk in women approximately double that in men, as best as we can tell? Why are some people resilient? Is there genetic influence here? We do think that there is some interaction between gene mutations and resiliency to stress. There's also some evidence that those are hereditary. So lots left for us to understand about all of this. Not to mention, what is the interaction with traumatic brain injury, with childhood trauma as a predictor, and all kinds of other things that are now being investigated. The third battle, of course, is, and we'll be talking about this today, how widespread is this, both in the returning population, the returning troops, and also in the civilian population. A RAND study that came out a year ago, based on a survey, suggested that 1 in 5 returning troop members were reporting PTSD symptoms. This was, of course, very quickly the subject of major dispute within the military and among the VA and so on. But that was at least one baseline report that perhaps the prevalence could be as widespread as close to 20%. Lots of questions being raised about whether the military has done an enormous amount over the course of this conflict. I think it's quite fair to say to respond to this, but the question remains, has it done enough? Have there been enough efforts actively to destigmatize PTSD as well as all other kinds of psychological and psychiatric conditions that returning troops can suffer, so that they feel comfortable about being open about this and seeking treatment? What is the implication of all of this for the civilian population? We know that as many as 1 million people a year suffer from traumatic events that also predispose them, lead them to express symptoms of post-traumatic stress disorder. So how do we apply some of the research that we're undertaking now on the military and veteran population and apply it to the civilian population? Because most of the people who are in the business of providing PTSD-type care for civilians will tell you that we are woefully under-resourced in that regard as well. So we have lots and lots and lots to talk about today, and just a terrific panel to bring all of that up. And I'm going to introduce them now briefly in alphabetical order, and then they will tell you a bit more about their perspectives on this issue. Ron Dozoretz, right to my left, MD, is the founder and chair of FHC Health Systems, which is a behavioral health service company, and he's the chairman of ValueOptions, which he'll tell us more about, which is, in effect, a managed care type organization in the psychiatric business, and he will give us more information on his relationship to this issue there, both as in his professional context and also as a veteran himself. David Scharff is with us also. He's an MD and director and co-founder of the International Psychotherapy Institute, which promotes the practice of high-quality psychotherapy and trains psychotherapists from around the U.S. and overseas. And will be telling us more about his take on the issue, too. Barbara Van Dahlen, PhD, is president of Given Hour. She is a licensed clinical psychologist. She practices in Washington, D.C., and has for 20 years. She specializes in children's issue, but she became very concerned about the mental health implications of the Iraq War and founded Given Hour to provide free mental health services to U.S. troops, to veterans, and their loved ones. And as of June of this year, the organization has over 4,200 providers working with it to provide this care. And then finally, Stephen Xenakis, who's also an MD. He's the senior advisor to the chairman of the Joint Chiefs for Wounded Warriors and Survivors. He retired at the rank of Brigadier General after having served 28 years in the Army as a medical corps officer in a variety of assignments, including clinical psychiatrist, staff officer, senior commander, etc. He's written widely on medical ethics and military medicine and has an active clinical and consulting practice as well. So, Stephen, since you have been most recently at the front lines of this issue, please, let's start with you.
Thank you. Well, good morning. Welcome to everyone, and I appreciate you hosting this and your summary to start off our conversation. We're each going to probably do about 5 minutes, and then we can open up for dialogue with you all. And I'd like to, in my time, speak to the overview as I see it from the senior leadership, and particularly from the office of the chairman of the Joint Chiefs, who he and I have been personal friends for a number of years. And in his first month of assuming the position, we were meeting with a group of young captains who had just come back. And they were telling us their stories about their experiences, and not only in the combat theater, but their experiences when they had come to their home bases and what it took for them to readjust and reintegrate. And Admiral Mullen, who is really an individual of immense capability and someone who I have the highest regard and respect, we got into a conversation, both of us who had served during the Vietnam era, about what we were worried about. And that as our memories lingered, not only of what we had experienced during that combat period, but also afterwards, and how how the war itself stimulated all sorts of changes and influenced much of what was going on in society. And in fact, one of those changes was the decision for the profession of psychiatry to establish or recognize that PTSD was an entity that followed certain traumatic events. There are many, many others, including the number of young men who ended up homeless, and the families who had difficulty adjusting. And so, as chairman of the Joint Chiefs and his colleagues, the other 4-star generals, these men and women feel the responsibility to convey to the policymakers, to the Congress, to the nation at large, what the effect is, what the impact is of going to war. They are the patient advocates. And it's an interesting twist in this conference because we've heard a lot about who should be a patient advocate and who should be accountable. And this particular, it's like a laboratory. This particular phenomenon that we have of these men and women coming back, in fact, are a laboratory of advocacy, a laboratory for engaging all the diverse service organizations and the population at large to come to bring to bear their resources and their best ideas. So in fact, the 2 million men and women who have already served, and many, many more who are going to serve, and their families will not suffer as many, many hundreds of thousands have suffered in the past. So for discussion, let me just throw out a couple ideas here that this phenomenon, or this experience we have with these combat people, I think could again serve as a way to shape the debate in the country for health reform. The first is a lifetime commitment. That we in uniform, when we ask young men and women to go in harm's way, we as a nation must commit a lifetime to pay them back for what they've done. That's not just rhetoric. We are not set up organizationally. We are not set up in our processes to, in fact, carry that out. And that's what the Dole-Shalala Commission found. They found all the gaps and the seams. They found that people were falling through the cracks. They came up with a lot of plug-ins. But in a way, I think those are 20th century industrial age and post-industrial age ideas that do not, in fact, capture what needs to be done in the 21st century and capture what should be truly a base commitment to these men and women. Secondly, is the idea that we in the medical profession, and I'm a recovering psychiatrist, are captivated by our ideas of disease and diagnosis. And we do great things, and I think Susan has certainly enumerated them. We do great things in research, and we try and find factors of what are causative agents and what are resilience and what we can do. But they miss the point. And it is really, for me, very interesting to sit with non-medical senior leaders who really look at us as physicians and just glaze over as we dive in to the esoterics of our profession. Because what is it that they see? They see Captain Kaplan right there, who goes to Afghanistan, walking around at an altitude like this, dehydrated, fatigued, not sleeping well, exposed to all sorts of stress that he may or may not have at all anticipated, and blasts and IEDs that we don't know what do to these men's brains, trying to keep himself awake, drinking coffee and smoking cigarettes, And because his favorite pastime is lifting weights, taking nutritional supplements, and he comes back here and he's a mess. What do? We say, well, I've got this checklist of diagnoses now, and I'm going to drill down each one of those. And we miss the point. Where does that lead us? I think that leads us to rethink what we're doing, and some of the ideas we hear. It leads us to look at a much more comprehensive way, what in some circles is called integrative medicine, and the power and the tools so people in the front lines can in fact identify and then reach out and touch these people's lives and help them. And we haven't really established those tools. We don't have them in place in terms of what we need to do. And in that way, it forces us to rethink how all the institutions that we established over the past 50 years then will change the way they work and how they connect. That we're not going to hand off people from the DOD to the VA to then the communities, which are really feeling the effects. The homeless rate amongst this cohort of OEF, OIF, Afghan, Iraq vets is 4 times what it was their comparison group in Vietnam. And those are young men and women who are falling onto the backs of our communities that are already strapped financially and struggling to figure out what to do. The last idea I want to leave you with is one of the ideas that Susan mentioned, is it's not about the disorder. It's about the fact that the lives of these men and women are changed, are different. And they're going to be different for the rest of their lives. And they're going to learn to live with it, some for the better, some who may suffer. And it's not just about treating the symptoms. It's about letting them optimize their lives and call it rehabilitation, call it something else. In a way, it's perhaps analogous to living with cancer for 15 or 20 years and still making the best of your life, even if you've had a particular bad event happen. And that reorients how we approach this. And so I think the debate at the national level, and if this debate can occur for us to take care of those people in uniform, perhaps that'll stimulate something broader across the country. And maybe that's what can influence, quote unquote, re-engineering the healthcare system. And hopefully reach out and and improve what we do across the country for all of us. Thanks.
Terrific, Stephen, and you've set us off on just an excellent agenda just with that. I want to turn next to Barbara. And Barbara, you've been intimately involved with some of the people Stephen was describing suffering from this and other.
Yes. Good morning, and I too am very pleased to be here today. I'm going to talk a little bit about the civilian involvement with these men and women and families. And first I'm going to tell you my story because I think it illustrates how those of us who maybe haven't had a lot of experience with the military, once we touch this population, can become very involved and very committed. I am, as you heard, I'm a clinical psychologist. I had a very busy practice in Washington, D.C., still do, seeing children, adults, teenagers. My personal history is that my father was a World War II veteran. He served long before I was born. He served in the Pacific. He was injured. He never talked about it. He would tell us stories about getting into fights and getting thrown in the brig, but he never talked about the battles. He never talked about his time in the hospital. He taught me about service. He taught me about integrity. And from him, I learned about, sort of vaguely, about this notion of why men then chose, primarily men chose to serve our country through the military, but it wasn't a huge part of my life. I grew up in the Vietnam era. My oldest brother was, I remember vividly, my dad pacing our kitchen floor because he was afraid my brother's number was going to come up to be drafted. And it wasn't, and my brother didn't serve, but the town that I grew up in was a rural town in California, And many of the men who went off to serve, those who came back, were different and terrifying to the children that I, grew up with, because they were strange to us. They seemed unusual. These were the guys who, often drove around on Harleys and smoked, and either, as my brother later told me, there were two groups of guys, his friends who came back from Vietnam, those who never talked about what happened to them and those who only talked about what happened to them, and there wasn't much in between. So that was my experience growing up, and then I became a psychologist, and as a clinical psychologist, I learned a tremendous amount about post-traumatic stress and what had happened to those who served in Vietnam. That's really what we learned so much from them. And so as this war started to unfold, I thought, okay, we know this. We know what's going to happen to these men and women. We're going to have this covered. And as I started to listen to stories coming home, men living out of their cars, losing their families, becoming homeless, as Steve said, I became very, very concerned about this new generation of men and women who were serving and what was going to happen to them. And as a busy psychologist raising two girls, I thought, well, I can't give up my practice and go to work at the VA, although then what later happened in my life, I've basically given up my practice to do what I'm now doing, but that's okay. So that was all percolating in my head, and I was driving around. I live, as I said, in Washington, and we were driving around in Bethesda, which is right outside of Washington, and as we often do, there are homeless veterans on the street corners, and I was with my daughters. My oldest now is 13. At the time, she was almost 9. And we saw one of our sort of typical common homeless veterans in his fatigues with a sign that said, "Vietnam veteran, please help, God bless." And my 9-year-old daughter turned to me and said, "Mom, how can our country let this happen to these men who served?" And I thought, well, that's it. We can't. And so I then started reading about forming a nonprofit. I had no idea how to do that. I read Nonprofit for Dummies, which I highly recommend if you ever want to start a nonprofit. It's very useful with the basics. And I formed Give an Hour. We are a national nonprofit organization that provides free mental health services to the men, women, and families who serve. And we define family as anyone who loves someone who's affected by the current conflicts. We now have, as you heard, over 4,000 providers. We've given out over 15,000 hours. It has been an amazing journey. Not only are we giving direct service in the typical way, that was my initial thought, was as a clinician, I would see somebody in my practice, I would add an hour to my practice, because that's how we shrinks work. You see people by the hour, and so give an hour. That was the concept. And what's happened, what we found, and Steve made reference to this notion of the breadth of this issue, these issues, how it affects our communities. So now what our providers are doing, which is really exciting for them and really critical, they're in the communities now. They're giving talks, they're educating first responders, they're supporting other veterans organizations at events. And if you want to get a feel for this population and the tremendous integrity and the honor, there's an event in Washington, D.C. that happens every year where those families who have lost a loved one come together and they're honored. And a couple of things about that event. We've been involved the last few years as a support organization. So we come in and we're just there and we're handing out water. And if anyone needs to talk, we talk to them. And these families wear T-shirts often that have pictures of their loved one who died. And it'll say, when they served. And these families are doing as much service for each other as they are receiving. They're asking each other, can I help you? They're picking up children that are sort of randomly wandering around. A couple of things about that event really struck me the first time I went. One, it was held in Washington, D.C., but if I had not been asked to come to the event by one of the organizations that was organizing it, I wouldn't have known it was happening. So the next year I looked in the paper to find out, was this listed anywhere? No. It was an event on the mall, and no one knew about it except for all the hundreds and hundreds and hundreds of families that were brought in. That really bothered me. That kind of experience that I've had led me to a couple of sort of additional paths, if you will, in terms of what I'm now doing. So as I said, our people are now working in the communities. They're doing talks. They're providing support. A huge issue that you've heard touched on already is normalizing this experience. I had a reporter ask me a few weeks ago. I get interviewed a lot now about what we're doing and why we're doing it. And he said, well, I don't understand. If somebody's this was actually in reference to a Marine that I know who had served in the invasion of Iraq. He was there for 6 weeks and then he came home. And the reporter had interviewed him and found out, this guy was really struggling since he's been back. And he says to me, well, Doc, I don't understand. Why this kid was only in there for 6 weeks? Why did it have such a significant impact on him and his life? And I said, okay, how about let's take you and let's put you in a car wreck today, okay? Maybe not a horribly traumatic one where you're, in the hospital, but pretty serious and maybe some injuries. And then let's do it again tomorrow and the next day and the next day for 6 weeks. What do you think that would do to you? And he said, oh, now I get it. We don't get it. Our country does not get it. If we put any of us in these situations for prolonged periods of time, for as little period of time as 6 weeks, you're going to have an effect on the individual. Everyone is affected. Not everyone comes home with post-traumatic stress. Not everyone ends up homeless, but everyone is affected. And if we don't support these men and women and their families, there are going to be long-range consequences in our society. One of the things that I'm now involved with, and I'm honored to be involved with, is the larger issue, which is how do we awaken our country? How do we alert our citizens that this is a long-term issue, that we have to get involved? We have to step up more than put the little sticker on our car that says support our troops. There are so many times I want to go up and knock on somebody's window and say, could you tell me what you're really doing besides the sticker thing? I really like that sticker, but could you tell me? But here I have a lot of compassion for all of us because most of us don't know what to do. We don't know how we can help, and hopefully we'll have some conversation today about what citizens can do. The other thing that I'm involved with is there are now thousands of organizations that have cropped up, thousands, to help the men and women who serve. Some of them are great, like Give an Hour. I mean, I am so impressed and proud, not of what I've done, but what our mental health professionals have done. They say to me when I go to conferences, I was looking for a way to help. I can do more than an hour. They want to give this, and they are giving it. And that is so amazing and humbling to be with these talented people who are giving their time. Lots of organizations are doing good things. Some are doing okay things, some are not doing good things. But there's no mechanism at this point for coordinating them, for pulling them together, to organize them. And so what happens, these men and women and families who are trying to get services, it's a hodgepodge, it's confusing, it's overwhelming. Luckily now, through the leadership of folks like General Xenakis, Admiral Mullen, some people at the VA, we're starting to pull this together. I was invited to testify before Congress on this issue, which was an honor, and talked about this as a public health crisis. It is. These people are coming into our communities and absorbing resources there. I was invited to the White House by our First Lady and Dr. Jill Biden. They held a meeting, and it's a sad statement about our country that most of us get very jaded about what our government is interested in doing, what it really can do. So as I was walking into this meeting that about 30 of us were invited to who are in this space of providing services, and people were kind of talking about, oh, this is going to be the same old, same old. It was a 4-hour meeting at the White House. They really wanted to hear from us what's being done, what needs to be done, and since that time, some other really amazing things are happening. So the last thing I want to leave you with is just a little story, because you can probably tell I really value stories, and that's what this is about, these people's stories. So this is my story, a recent story. I was on a train heading up to New York to work with some folks in this space that we're all dealing with, and a young man got on the train. Gorgeous, about 28, 30-year-old, probably 6'2", big, broad shoulders, strapping young man, strong, chiseled features, and a prosthetic arm. And he had a cap on that indicated that he was a veteran. And I sat there looking at him, and I watched the people around him, and I watched them not knowing what to do. You couldn't not notice this guy. And he was not making eye contact. So he wasn't making it easy for the people around him to thank him, to ask him any questions, and none of them knew what to do or how to approach him. And I sat there and I thought about all the ways that this issue, whatever happened to him that resulted in the loss of his arm, how that's going to affect his life for the rest of his life. I thought about, well, whatever happened that caused that injury was probably traumatic. So probably he's suffering some degree of post-traumatic stress. And you won't hear me use the word disorder because my focus is on normalizing this. It doesn't become a disorder unless we don't do anything, unless it becomes chronic, etc. So, and then I thought about, well, I didn't see a wedding ring, so I thought, I wonder, how's he going to be able to date? How is he going to deal with intimacy? The whole world of sexual intimacy for these men and women. Can you imagine being in bed with someone and the clatter in your head of trauma and, feeling all this intensity, which is what you feel when you're with your partner, can trigger all this intensity that's associated with seeing people dying? So I thought about that, and I thought about, is he working? Does he have a job? He's clearly young and strong and powerful. Is he going to school? How is he doing if he's going to school with all the kids on campus who aren't like him? And his family, did they have to quit their jobs to go and live with him near Walter Reed or one of the other hospitals while he went through all the surgeries? This is the spectrum that we're dealing with. And our country needs to wake up, and we need to step up, and we need to, as Steve said, provide for these people for the rest of their lives. Thank you.
Thank you so much, Barbara, for telling us like it is. David.
Well, I'll try to build on what Barbara and Steve have been saying. I come to this topic with a number of things in my background. I taught at the military medical school for 6.5 years, having known nothing about military culture, and found these young men to be really admirable in a way I had never understood. And the job they were doing, because they loved medicine and never expected to make a lot of medicine. Turns out it's a better place to practice than has evolved for the rest of us since then. But they didn't know that. I've been teaching military residents in psychiatry for almost 30 years. I've done a book on the survivors of childhood sexual and physical abuse that really is relevant to this because so many of the soldiers that we're talking about actually more and more come from disadvantaged backgrounds where there's been a lot of developmental trauma that predisposes them to do worse when they face these battle traumas than they would otherwise do. It's a reason why I think the Marines do so much better than the National Guard and the Reserves, who come from much shakier family situations very often. And I think we have to keep in mind that what happens to these people is on a spectrum. There are some battle traumas that are so severe anybody would have PTSD. But there are many that, with predisposing factors, make it much worse. And that those who have good family backgrounds, who are there because they want to be, as the Marines usually are, who have good coherence in their operating units, they do much better. And my last qualification is my son-in-law, who led the platoon that was the spearhead going through Fallujah, in the Battle of Fallujah, and from whom I've learned a great deal, including really how much he cared for his men who cared for each other. So they came home with a 50% casualty rate and no fatalities. But when there have been fatalities to their friends, as there have been, he said to my daughter, I'm much too young to have lost so many friends. They talked about it and talked about it and talked about it. They went back to the graves a year afterwards. They helped the families. That kind of coherence really helps. And there are so many of these troops, especially the ones who come from the National Guard and the Reserves, who don't have that. They don't live on the base, so they don't have that kind of support. They come from areas where they're the only one. That isn't always true, but often true. They often come from disorganized families, and so the qualities that lead to resilience and to being able to survive these things with a psyche that's intact really don't help them. And I think these are the ones who are the most likely to be homeless and to have trouble. The other thing I wanted to add to this discussion, which Barbara has already talked a little bit about, is that of these 2 million people who've been deployed, and the more that are going to follow, the traumas that happen to them happen to their families. Just the deployments alone are traumatic for many of the families. And if we figure roughly 6 family members, a couple of kids, a spouse, and some parents, we're talking about at least 6 people. So we're talking about something like 12 million people who are directly affected. And then the ripple effect for that is much more like 40 million people who are affected by what happens to these soldiers and sailors, Marines, airmen. And we're not really thinking about that as a country. There are organizations that are thinking about it. I know Barbara's thinking about it. There's a group called founded by a colleague of mine named Ken Reich, Barbara knows well, called SOFAR, Strategic Outreach to families of all reservists, where they have been really working to do preventive intervention with them, positioning themselves to be there when there is trouble, helping case finding so that when people come back from deployments and don't want to talk to anybody, the families can seek them out, all these kinds of things. But this is really a national problem, and without the kind of interventions that we need on really a very large-scale level, I think we are positioned to have the kind of trauma that Vietnam was to our country, where our country really was so traumatized by the Vietnam War and the way that things ended up with its being so unpopular. I think at least the ribbons do show us that as a society we actually support these people, whatever we think of the wars, but that we regard them as honorable and of doing service that most of us don't ever do. I think that's important at a social level, but they also need the services and they need it for their lifetime.
Great, thank you, David. And Ron, we'll turn to you.
Well, thank you. I'm proud to be part of this panel. It is a remarkable group, and my story is I've been involved in this field for pretty much all of my professional life. When I got out of my training, Case Western Reserve as a psychiatrist, I went to Virginia as lieutenant commander in the Navy for tour of duty, and became very interested and involved in treating Vietnam veterans. And that stuck in my mind, and it does until today. And when we were finished with that, I helped establish the Vietnam Veterans Association of America. In fact, the president of it worked for ValueOptions, our company, and we were deeply involved in that. During the first Gulf War, we had been working with the military, and we secured a contract for several 100,000 people in what's called Tidewater, Virginia, and we helped organize and manage the mental health care for the military. That small contract grew to ValueOptions, where we now serve around 23 million people across the country. About 3 million of them are military active, military dependents and families. When we dealt with the first Gulf War, we had a huge amount of control and organization with it, and we literally followed everyone as they went. So as they went in, we did assessments, and as they came out, we did assessments, and we followed them, frankly, for years wherever they went, because they obviously went all over the country. There is a sentence, I was hoping she was here. Brigadier General Lori Sutton was here yesterday, and she's probably here. And she's head of the Defense Centers for Excellence for Psychological Health and Traumatic Brain Disorder. And she is, in testifying before Congress, gave this sentence. She says, "Never before in the history of our republic has so much been placed on the shoulders of so few on behalf of so many for so long." We have been trying for the longest time, because I our organization, we understand systems and large numbers of people and so forth. And it's frustrating when you have somewhat of a solution, but it's very hard to make that happen. There are, as Barbara said and others, there's huge numbers of information around. But the reality is, if someone today in Boise, Idaho, or in Montana, or any small community, in fact, the young man who was captured from Afghanistan, in fact, lives in Haley, where we have a home in Sun Valley, and Haley's 5 minutes from where we are. So when those people want to get care, there are massive amounts of information, but it's not coordinated. It makes it very hard. There's 800 lines. There's huge numbers of websites. But it isn't coordinated. And what I have and other people like me have said is there is 2 million people, and that's a lot. But the reality is, in the scheme of people who do what I do, it's not a lot. It's another number. I mean, we manage millions and millions of people. And the really solution to this thing, as Stephen said, is to organize every person as they get out. If you can't do it when they get in, and you literally put them on a single database, and you follow them. The problem that you have is that the guard it does not get the level of care that other people get. And the level of care, frankly, between the Marines, the Army, the Navy, and the Guard is very different. It is not coordinated. And the rate of suicide in the U.S. Army today, not yesterday, this is today, is at the highest level. And 09 is the highest level it has ever been, and it is trending higher. Now, there's no magic solution, but clearly one solution is that if you have everyone on a database and you follow them getting out, and then you follow them on a regular basis, 2 weeks, 6 weeks, 8 weeks, or whatever the number is, as people like us do, and then you look to prevent care, because people like us understand prevention. We understand the signs, and you have them fill out forms, and you have them do interviews. You can prevent. I mean, it breaks the heart of people like me and everyone at this table to have a young man or a young woman whose rate of suicide is certainly twice that of men kill themselves. Because what is suicide doesn't affect just that person. They're gone. But look what it does to the universe of their family. And families frequently never get over it. The kids never get over it. It affects them for years. And there is things that we can do. The military has done an unbelievable job. They have, and particularly in the last 2 years, they've put massive resources in this. But until we get together a common base where we can follow everyone in the same manner, in the same form, in the same systems, then we're going to miss things. If you look at all of the people who have asked for care, it's around 39% roughly. Around 61% of the people have not asked for care. There's a physician named Dr. Cudler out of Duke calls it the unknown, the missing 61%. Now, we don't know what happened to them. They may use private money. They may not want to do it. Whatever it is fine. But as citizens and responsible community leaders, we as an organization, as a country, should know what happens to these people. We should find out, and we should try to get them care where they live. They're not going to travel. There's 200 VA facilities around. But if you're out living somewhere, how are you going to get there? How do you drive there? But there are 60, 70, 80,000 providers in an organization like ours, and others. We're not alone. There are others. And so you get 100,000 providers, not 200 facilities. What does that have to do with anything? And you organize the people who need the care in the communities where they live, and you engage the families, you engage their employer, you engage everything so that they are comfortable where they live. We understand. My son was asking me, why would somebody like this get into trouble? I said, just think about this. When you take a picture of the military person, He's with his helmet, he's with his uniform, he appears huge, and he's got a gun, and he appears very, massive. And then he gets out, and all that is gone. And he's just like the rest of us. He's not so massive, and he doesn't have a gun, and he doesn't have a helmet, and then he has to adjust to everyday life. This is a huge adjustment for these young men and women. And I would hope that sometime we could do this, and I'm very proud to be on this panel.
Great. Well, thanks all of you. You have really given us a tremendous amount to think about. Stephen, I want to come back to you because you mentioned the Dole-Shalala Commission, which identified a number of things that ought to be done, and you did address some of them. One is, as Ron had just said, improving, in effect, the systemization of dealing with this so that people don't get lost between the DOD and the VA. And we know some very real obstacles to that there are two completely different electronic medical record systems between the DOD and the VA. And, of course, the effort now is to harmonize those so people don't get lost. We know that there was a lot said about giving people access to civilian providers, not just confining them to the VA facilities or the military facilities. What's happened? Are we making progress on those things? Are we getting to this level of systemization that Ron mentions is so necessary?
Yeah, I think there are a couple things that we're doing that, in fact, might have implications in general in health. One is that in terms of the electronic medical record, the president had announced the VLAR, the virtual life record, for anyone from the time that they come into the service. And it is a comprehensive record. It's just not medical, it's all other personnel data. And that will be established at the time that they enter service and will follow them for their lifetime.
And what's the timetable on that?
Timetable is a little fuzzy right now, but and all the technical aspects of what needs to be done, which is a sort of a major re-engineering of our understanding of about health information and knowledge. I mean that where we keep the data and then how we access data in terms of the other applications. And so I think they're looking at probably a 2-year time cycle, but don't hold me to that. So that is launched. And frankly, if that does get set and we can model that and show that we can have a repository of all sorts of data and then have some flexibility of how applications get to it, that could be something that's very useful, which means that, and I think Ron's brought on some excellent points, it means that providers in a community where particularly a Guard or Reserves service member, 40% of the 2 million who have served are Guard and Reserve, then the providers or the employers or the schools, they can have access to the kinds of information that they need. So, in fact, the person can get what deserves and what will help them the most. So that's one initiative that's happening. The second initiative has to do around disability evaluations. Currently, a soldier, I say soldier because I'm Army, I should say a service member, has an injury or illness that some way or other restricts performance of duty, then there's a disability evaluation within the military health system. And a decision made about if the person needs to be medically retired or separated, and what the compensation would be and what their eligibility is for care following that. The person, if separated and or medically retired, currently then goes to the VA and gets another, it's redundant, disability evaluation.
And they're often in disagreement with one another.
Often in disagreement. And you can imagine how that plays out. And not only, and the soldier service member gets consumed for a couple of years, and that process is protracted. It can take a couple years to do that. And they get absorbed in their disability. Well, that's that's really oriented probably in the wrong way. It's strong, but because what we're doing is we are focusing the energy and attention of the person on their aches and pains, not on what it is to be moving forward. And so the first step is there has been a pilot at Walter Reed to have one disability evaluation, and it turned out very positive, and it is now getting fielded at other medical facilities, and we're looking at how we're going to bring the VA folks and the military folks together to do that evaluation. The second step, which is the bigger challenge, is how we rethink what is a disability or an ability. What Admiral Mullen likes to say, and I think he's got it spot on, is the VA should be a full employment and full education organization. And the service member who's been injured or had some other trauma is as expeditiously as possible. It's one of the principles we learned in military psychiatry early on. Expeditiously possible, oriented towards growth, oriented towards their future. Now that's a major change, because it's a major change within our military VA system. It's a major change in terms of how we do disability compensations across, the country.
And does that include basically keeping people in service and not forcing them into retirement?
Absolutely.
Notwithstanding disclosure of often severe.
Is upfront saying to them, Captain Dentzer, what do you want to do? What do you think you can do? What would you like to do? What do you think you need at this point? And how much time is that going to, what can we do to help wrap the support around you, so however long it's going to take for you to, make the decision, because it's tough. I don't know how many of you, you lose an arm or a leg. I unfortunately have all my limbs, but I have spent a little bit of time as a patient. It takes a while to really understand what that injury has done to you, and then to know what you think you can do. And we start putting people through an assembly line here in their checkpoints, and sometimes dehumanize it. So we need to do that. What do you want to do? What do you think you can do? What does your family want you to do? Where do you want to do that? I mean, this is a complex systems of systems. That's a major thrust here, and we're just opening the door for that. But the good thing is we've got the conversations here to do that. And then the third thing that we really need to take on is, in fact, sort of connect the DoD, VA, private sector healthcare delivery system, and what I would like to call functionally integrated. We've got little clinics in places. We've got hospitals in places. There's duplication. I commanded in Augusta, Georgia for a while. We had a medical school, a big VA center, and a military hospital. We really all didn't need to each of us just restrict ourselves to our little domains when we're all in the business of public health. I mean, we could buy equipment together. We could have one rehabilitative unit. There's lots of things we need to do that. We're starting those conversations. That's, I think, something that we'll have to take on. So,
thank you. Those are all very hopeful signs. Barbara, you mentioned the word normalization, and often the phrase destigmatization is also used in the same context, but it's basically telling people that this can be a normal response and offering the kinds of supports that Steve just described. Do you, in dealing with some of the individuals you've dealt with or your providers in your organization have dealt with, do they feel that there is a change? Do people who suffer these conditions now feel that they are coming forward in a context where there is more normalization to it?
I think there's definitely hope. I think we're moving in that direction. It's interesting that we get calls and emails from parents and from servicemen and women themselves, and there is this hopefulness. Sometimes it's after a tragedy, which is painful. We've heard from a couple, I'm thinking in particular, parents who their son committed suicide, and he was a reservist, and he was one of the ones that fell through the cracks, and he was the kind of person who took care of others. And they said to me, you know, they're coming to us because they want to help. They want to reach out and help educate. And they said, you know, we didn't understand. He was struggling, but we thought he's been through so much, we just want to leave him alone. And so, but what they said is that as we're now reaching out to other families, families are appreciative that people are reaching out. So I think that's what's changing, is that there's an awareness. And again, you know, some great things are happening. Admiral Mullen and Secretary Gates have come out very strong from the top, making statements about it's courageous to seek help and seek care. It's going to take a long time for that to trickle down to the sergeant, who still kind of busts on his men if they act like wimps, or other terms that I won't use. So we're still hearing that. But I think that many of the young men and women that we're talking to who are seeking help, they've grown up with a different view of therapy, and counseling, and the fact that we're all working so hard to normalize this and to talk about the analogy of a car crash and all that. What we're finding is that more often when they get in the door, they grab onto it and really feel like, oh my God, yes. And then what do they want to do? They want to go tell their buddies. So I think there's a lot of hope. And that's why we're obviously pushing so hard this message and this issue. The other thing I'll say that is about mental health in general, Steve was saying that this provides a model and opportunity for healthcare reform. It also provides a wonderful opportunity to get mental health out of the shadows, to talk about issues like anxiety, depression, as they're related to post-traumatic stress and the experience of war, but also just in general. And so it gives us an opportunity as a country, I think, to have much more open, honest conversations about mental health in general.
We do want to open this up to conversation among all of you. And Phyllis.
Well, I've got a couple of points that I want to make. First of all, there really has been very little focus on women in the military. And my organization, Society for Women's Health Research, working with DOD, VA, National Institute of Mental Health, and American Psychiatric Association, held the first scientific symposium looking at sex differences in post-traumatic stress syndrome for women. There's really nobody knows how to treat women. The treatment that's been used, which isn't very successful anyway for anybody yet, doesn't work on women hardly at all. So there's a whole area of research that needs to be done. Second of all, we haven't even talked about the fact that women suffer disproportionately, not only from post-traumatic stress syndrome in terms of combat, which is another issue we'll get to, but also because of rape and psychological and sexual abuse, which is ongoing as we speak now. It's not getting any better. In fact, maybe even getting worse. Also, when they seek help at the VA, they're dismissed because they're not in combat in the official form terminology. But we all know that they are in combat, because if you're sitting next to someone in a vehicle and it blows up and he's blown away, you're in combat, even if you're not on the front lines, of which there aren't anymore, as you know. So the treatment in the VA is deplorable. I've testified twice on Capitol Hill in front of the Veterans Administration with about 10 other women. And if you sit there and you hear their stories about how they're treated in the military and how they're treated in the VA, and the lack of research on how to treat women, it's really appalling. And actually, the Veterans Administration has come to us to ask us to do research on how to treat women with post-traumatic stress syndrome. So with everything, and we're working with Give an Arrow, we're working with some of the other women veterans organizations that have popped up, and a couple of them that actually are going national through the internet, which obviously is a great advantage. But in all your presentations, there was no sense that there's a real difference here. There's real science.
Phyllis, I think you came in a little late, and actually in my opening comments I did make that point. And we should pick up on that, because one of the major studies that was done at the VA, Matt Friedman's operation up at the National Center on Post-Traumatic Stress Disorder. It was done among women. It was And it was the prolonged exposure therapy trial, and it did show some astounding results. And so the question arises, why hasn't that been rolled out more quickly? Now, when you ask the VA that, they'll say it takes time. It takes time to train the people to do this therapy. Steve, do you want to add to that? Is that how long can we wait?
Well, I think that's one of our challenges here, and it's one of the aggravations of the non-medical senior leadership is how do we take a finding like that we know needs to be fielded expeditiously and in fact push it out to the field in a much more effectively than we do currently. And there are any number of these developments or research that we have that in this, I think we are, unfortunately, we've tied ourselves again as a medical profession. The nuance is that that for the administration in the Department of Defense to then make a policy, and the laws that restrict the administration to make a policy, they are more or less bound to have data from a sort of level 5 study, which is a randomized controlled trial. So even though Matt's done some very good preliminary work, it does not qualify as sufficiently compelling data.
It has to be replicated.
It has to be replicated. Well, by the time you do that, the game's over. And so how we have not, in fact, figured out how we take something like that and use those lessons learned and within the bounds that we have to live with that are prescribed by the Congress, take that information and push it out to the field. And there are any number of these that our senior leaders, as I observe and in fact work with them, feel like we need to get out there. Now, the issue about the women is itself something that is missed in so many ways and has real serious implications in terms of understanding the culture, which we've not put a lot of time and attention to really looking at the military culture in all its ways and what that culture is and how it works in an environment where we're trying to keep villages safe and families safe, and how we take more combatant mentality and shift it to this, and then what it means for the women who are serving alongside with the men in this environment, and how they are. I mean, all the anecdotal reports that we have not documented about sexual harassment that they experience, which is, again, how we're supposed to handle that in a horribly stressful environment. That when you put, we put people in combat in Afghanistan carrying 100-pound packs, dehydrated, hypoxic, not able to sleep. Young folks, how are they going to express their stress? And how do we work with that culture and look at unit cohesion and influence the leadership to understand that that is a challenge that we have here?
Just one quick comment. One of the things that's changed, and listening to you, saying the VA is now reaching out to you, the world has changed dramatically in 4 years in terms of the willingness to open the doors to organizations like ours. And one of the things that's really exciting and is directly related to the women's issue, there's an organization that has an MOU with Memorandum of Understanding with the VA to look at innovative technology to do exactly what Steve said needs to happen quicker. And they're going to use organizations like ours. They're going to take our 4,000 providers, say, here's a treatment we now know works for women. Let's get it out to these providers in the civilian community. Let's get them training. So things are going to happen faster because the world has changed. It's not happening fast enough, but there are a lot of people who are mindful, and thank goodness the doors are now open for that kind of collaboration, and that wasn't the case 5 years ago.
Yes.
What percent come back with this disorder, and what are the common symptoms?
Well, I mentioned the RAND study that was based on a large survey that was done that said 1 out of 5 returnees report that they have some of the symptoms. And I think the related to that was that almost 1 in 5 are also reporting that they believe that they were affected somehow by traumatic brain injury of some sort. Now, there's debate over that. And
basically, David will talk about it, but it's basically depression, anxiety, sleep disorder, suicide thoughts, anxiety.
Well, in the most extreme cases, it's this very intense reactivity, flashbacks, and behavior that is intolerable in their families often, isolation, and suicide attempts, and
substance use.
Substance abuse, alcoholism. But I think that we've really been talking about a wide variety of things, of which PTSD is probably the most dramatic and identifiable, but it's a whole continuum, and then it's a larger group. Then it isn't 1 in 5. It's really...
The normal psychotherapy is the best way to deal with it?
No, I think we need a multiple armamentarium to deal with these people. The psychotherapy alone doesn't deal with the PTSD. It works better for the anxiety and depression that are a shift down on the continuum. But they need specialized treatment. There's no question about it. And drug therapy too. I mean, they're all sorts of, what they actually need is well-trained people. And I just wanted to add that I think in the military, my experience of the training that's done for the people who become the diagnosticians and therapists for this, they're actually better set up to keep the military functioning in an ordinary way, kind of in peacetime. And there's such a huge machine that so much of their training goes to just keeping things going. So when there is one war or two wars, fairly little of their training has actually, is that right, Steve? That's my impression from working with them. So actually they need more, the service deliverers need more support for giving these things. And then if there's a new treatment, you do actually have to train people to do it.
And there's nothing you can do before they go in to prepare them?
That's the great discussion.
Yes, there is. Yeah, there is.
Well, and part of it, there's work going on now within the military to, first of all, identify the features of resilience. And we know that matters here, whether it's biologic or other or environmental, and how you support that. So there's work on that score. I think it's also the case that there's, on the training side, I sat through a very interesting discussion involving some nurses who had actually had been raped, who had gone through the prolonged exposure therapy discussions, or treatment. And, it's not rocket science. It's not hard.
No, that's true.
It's basically what they did was, after one woman had suffered and been in and out of treatment for 10 years, had gone off, she'd gone into the Gulf War, she'd served, she'd come out, she could not stand being with her fiancé anymore. The engagement broke up. She suffered for years and bounced around at treatment at various VA centers. Then she goes into this trial, and what does the therapy consist of? Every day, well, not every day, about 3 times a week, she'd go and she'd talk for an hour about what happened to her. And she'd tell the story over and over and over and over again for 6 weeks. And bingo, that's what did it. Because she became, we now understand enough about the brain that what was happening was she was relearning and developing new neural pathways to process the trauma.
Well, I think just in more specific neurologic terms, the amygdala is the fear center, and it's a first responder. It's part of the lower brain. And in these very severe traumas, that rape, IEDs, it gets sensitized and it won't quit. And it is whatever it takes to get the higher brain centers to be able to override this first responder, which treats the whole world as a danger situation. And I think we know a lot about, the military is taking more people who come in with their amygdala already on fire. And they're not going to do as well.
Arlene, and then we'll come back over again.
I was wondering, when these servicemen and women come back from conflict, are they kind of debriefed and depending when they come back, or do they just let them go back home?
You might want to say a word about what's required in terms of the...
Yeah, there's a whole set of process of a month period right now that they go through a kind of reintegration back into their installations. We, as Susan's mentioned, I mean, there are a lot of initiatives we are looking at, and there's a lot of work. We know a lot about how to prepare people, and not as much as we need to know. We know a good deal about what it is for them to return, and we're looking at a whole other set of options. One interesting one, which is going to be difficult because our numbers, is the European countries do what they call third location decompression. So the Canadians go to Cyprus, and the Brits sometimes go to Cyprus, the Dutch go to Crete, and they'll spend like 2 or 3 days, and they'll just blow their pipes out. And it seems to help. Some of our special forces do the same thing, and it seems to help them. What we do now for the larger volume of soldiers is something that we've got to tackle.
The problem that we found is if they say they're troubled, they're not going home. So they usually don't say they're troubled.
They want to get out. They want to go home, and they'll say, I mean, they'll tell us this. Yeah, they say, yeah, I got that form that said X, Y, and Z, and I just said no, because they want to go home, and that's why now there are efforts to follow them and do follow-up. And just to go back to the question about counseling and one of the things that we hear that is so important, and sometimes it takes finding the right fit of treatment for that person. For some things work, different things work for different people. But one of the things that we hear over and over again, which is so important, is a guy, a gal will say, I thought I was going crazy. Now I understand that this is what my brain is doing. So just the educational piece of explaining to them is like, oh my God, at least then they can start. Instead of feeling like crap, like I'm a failure, I'm weak, I'm no good, they can start to figure out what kind of treatment can be helpful to them.
We'll make this the last question because some folks have to move on.
My name is Ken Kaplan. As disclosure, I'm an advisor to the Secretary of Health Affairs, Department of Medicine, the Surgeon General at MIT, and my background in architecture. I started as a psychiatric social worker, doing a lot of counseling, actually in drug use. I just wanted to endorse General Xenakis' vision. I think that he's on the cusp of, I think, launching right approach to this problem. And I think that looking at this bigger system that we've created, the country's created, that goes back to the beginning of the formation of American republic. I think the military is a centerpiece, actually in health. It's been a leader, progressive leader, so many, including infectious disease, Walter Reed, and so forth. And I think he's right. I think that the role of the military play in health reform, particularly this issue, having coming out of the psychiatric world, you're doing a better job than the Smith side for years. Smith, I left that in frustration because of the lack of infrastructure systems in that world. It's not just psychiatric world, it's the whole medical world, but that particular world is the least infrastructure rich, you know what I mean? And I think Steve's got a vision, and I think it's so timely, and I think his position is so critical in terms of working with the leadership, which is historic, that we've had Admiral Moulton and General Corelli concerned about mental stress and illness. And I think, unfortunately, we have a civilian leadership that's not as worried about it. And I think that even though there's a lot of lip service to it, if you look at go into the fundamental into the details of what's actually happening, and I think the key leader in this will be the president. I think this is a presidential challenge. He's the commander-in-chief. This is his problem, and I think he's going to have to fix it. And I think there's ways to fix it. And I think just on that note, I'm just my editorial.
Well, an excellent note to end on. Let me thank this panel for a terrific discussion. Thanks a lot.